Welcome. This week, we're going to talk about the next section of chapters or the next chapter of sections in the ICD-10 PCS code set. Now, you remember ICD-10 PCS is used solely for reporting hospital services provided to an inpatient. This patient must be admitted as an inpatient. Okay? That's the only circumstance under which you will use this to identify procedures, services, and treatments provided to that patient. And we have already learned about the med-surg section, medical and surgical, and you learned about obstetrics. Now, the next several chapters are going to cover a large number of different services, placement, chiropractics, measuring, acupuncture, okay, and all sorts of other services such as that. And so now that you have gotten a handle on how to use the ICD-10 PCS code set, you know, by finding the correct table with the section, the body system, and the root operation term, and then building the other 4 characters within that code. So now we're going to go over some case studies so you can practice how you identify different services provided from the documentation so that you can then code them. Because obviously that's the first step. You read the documentation very carefully. You identify what was provided to the patient, what was done to the patient, or what was done for the patient. Okay? And then you interpret that into a code. All right, so let's take a look at the first case study. This is a cardiac bypass grafting. And yes, that primary procedure is going to be reported in the med-surg section. Okay. However, that's the thing about these additional codes, these additional sections, is they may be the focus, the one and only focus of the procedure or service, but they also may come accompanying other procedures and services, and therefore this will result in you determining codes from several different sections. Remember, you learned this in ICD-10-CM with diagnosis coding. You may be hitting several different sections of the book to tell the whole story of why this patient needed assistance, needed the care of a professional. Same thing where you're going to read the whole documentation and find out what codes, whether it's 1 code or 3 codes or 10 codes, that need to tell the whole story about what was done to or for this patient. Okay, so let's take a look at this together. With satisfactory insertion of monitoring line, induction of anesthesia, standard prepping and draping for the chest operation, a media sternotomy was performed. Now, this is where this is why we made you take anatomy and medical terminology, right? Okay, so what do we know is we have the induction of anesthesia. Now, remember, that's going to be reported by the anesthesiologist coder with CPT. That may be you, it may not be you, okay? Standard prepping and draping for the chest operation, a median sternotomy was performed. So what does that tell you? That tells you median in the center, sternotomy, stern as in the sternum, otomy as incision into. Okay. Okay, so that tells you what? It tells you this is an open approach. We dissected both internal mammary arteries and their pedicles, opened the pericardium, and heparinized and cannulated routinely. Okay? Cardiopulmonary bypass was initiated. So that means that they basically disconnected the patient's heart, and now there's an external machine that is taking care of oxygenating the blood and sending it on its way through the rest of the body. Okay, but this is being done on a machine. That's why cardiopulmonary, heart, lung bypass means it was disconnected from the body and is now being put through a machine. And this is, when you think about it, right, is the heart needs to keep beating for the patient to stay alive. Because when the heart beats, it processes the blood to go through the arteries, and then the veins bring back the deoxygenated blood into the lungs to get reoxygenated and onto the heart, right? You can't stop this or the patient will be dead. So we don't stop it, but we disconnect it. So the machine is doing this circulating, if you will, so that the surgeon can then work on the heart and the coronary arteries and veins without it constantly moving. Could you imagine that? Could you imagine trying to cut into something that is constantly beating? You can't. Okay. So cardiopulmonary bypass, that's what it means, is to connect that to an external machine to do that job. Okay. Temperature dropped to 32 degrees. The colder the body is, the slower the blood flow. So this helps the surgeon have room to work, okay? Myocardium was immediately arrested with aortic cross-clamping and infusion of aortic root blood cardioplegia initially, supplemented by retrograde cardioplegia through the coronary sinus. Okay, you remember the myocardium is the muscle that surrounds the heart. Okay, we performed 2 end-to-end distal anastomoses. It's amazing to me. Some medical terms just roll right off my tongue, and others. Okay, using the mammary artery. The left internal mammary artery was passed toward the left anterior descending through a vent made on the left side of the pericardium. Now, what I will tell you is, when you graduate, if you do work for any specialist, and I'm going to say in this case a cardiologist, keep that anatomy book close by. I find that when I can be looking at the drawing, at the illustration of the heart, and I can see what they're doing on at least the pieces parts on the illustration, it helps me get a clearer picture of what is going on. Okay? All right. as we did with the right internal mammary artery passing through a vent on the right side of the pericardium. So I just want to point out, so here at the bottom of this paragraph, we have the left internal mammary artery and the left anterior descending. And now the next paragraph says the right internal mammary artery passing through a vent on the right side of the pericardium. So what does that tell you immediately? This was bilateral. Okay. Both distal, there it is again. Okay. Anastomoses were done with continuous running suture of 7-0 proline. Okay. Now, what kind of suture was used is not going to get coded. It's not necessarily something you need to know, but it needs to be in the documentation. Okay, so this is part of your critical thinking process, part of using your education. As you read through all of the documentation, you will come across things that don't have any impact on you. But as you do this time and time again, you will get more educated. You will get more comfortable with exactly how these procedures are done, which means you'll better understand anomalies when something is done differently. Okay. And when it is all the way it's supposed to be. Okay. All right, rewarming was in progress, which means they're now warming the patient back up from 32 degrees. Cross clamp released. Okay, so the grafts are in on both sides. And remember, what is anastomosis? Okay. What is that? That means that they have confirmed that whatever revision, whatever adjustment, whatever cutting and sewing they did, the blood is running through and there are no leaks. Okay? That means everything has been replugged back in clearly, carefully, and it's working. Okay? Myocardial activity resumed spontaneously. Excellent. The heart muscle is now back to telling the heart beat, 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 beat. Temporary atrial and ventricular wires were placed and pleural and mediastinal cavities drained appropriately with chest tubes. There was satisfactory hemostasis. Again, hemostasis. Hemo, blood, stasis, activity. So we're all put together back. Everything is fit back together again. Okay. Decanalization followed. So now they took out the cannula. Heparinization reversed with protamine sulfate. So heparin is a medication that thins the blood. And definitely when you are operating on a heart or major arteries and veins, you do not want to encounter any possibility for blood clots to happen, because that's problematic. You know, blood clots are like when a car breaks down in the middle of the expressway during rush hour. It just stops everything and gets all cluttered and stuff. So we don't want that. So they will introduce heparin to thin the blood to make sure that everything is flowing properly. But you want to bring this patient back to normal clotting factor. So it was reversed with protamine sulfate. Okay. Sternotomy approximated with interrupted number 6 wire. So they wired them back together again. The linea alba, fascia, subcutaneous tissue, and skin were closed in the usual manner with continuous and uninterrupted sutures. A nice blanket stitch would be nice. Okay, the patient was transported to the ICU in satisfactory condition. So the linea alba, the fascia, the subcutaneous tissue, and the skin. You remember in anatomy class and medical terminology class when you learned about all the different layers of the integumentary system of the skin. Okay, so they had to stitch that up. And if you all took CPT class, you may remember learning about the different layers of the skin when there is a repair, right? Those deep repairs as opposed to a superficial repair or an intermediate repair. So you're talking about the same parts of the layering of the skin. All this is not going to be reported separately as it might be in CPT for repair, because this is obligatory. Once you cut open a patient, you must close that patient deck. That's, it's just the polite thing to do. Okay. So, are you ready to think about what codes are going to be necessary? If you want to practice this on your own, I'm going to skip over the next 3 slides. So you can practice this on your own. And then, of course, the recording will have the answer key, the answers on the next 3 slides. So you can see if you got it correctly or what is correct. Okay. So my mouse is playing hide and seek. All right. Close your eyes. 1, 2, 3. Okay, you can open your eyes again. If there were more students here live and in person, we would work through these together. But because the majority of you are not here, I want you to work on that on your own and then check your work. And of course, I only say this about 1,000 times, but any questions, email me and I will be happy to discuss it, to explain it, to work it through with you. Okay? All right. Here's another one. Arterial catheterization. Very common when it comes to cardiology and other measurements that are necessary. Excuse me. And this is a nice short op report or procedural report. Arterial catheterization. So you remember from medical terminology, that means insertion of a catheter into a artery, arterial artery. Okay, so patient was placed on the table in supine position, facing upward. Local anesthesia was administered. Once we were assured that the patient had achieved no nervous stimuli, so they did local anesthesia, right? Just where the incision is going to be made. The incision was made, it's not on the hand though. It's on a place where I cannot politely show you. It's most likely going to be on the inner femoral, going to the femoral artery. Okay. The incision was made and the catheter was introduced percutaneously through the skin into the heart. Now, you might say, why did I say that it was most likely the femoral artery, which is in the thigh when we're going up to the heart? Because the femoral artery leads to the heart. And if you pull out your CPT book, you will see it has a graph showing all of the stages, and also in your anatomy book. Okay, when you look at the artery, look at the femoral artery and how they can thread right up there through the body right into the heart. It's actually amazing that the point of entry being all the way down here in the thigh is the best place to get to the heart. But that's anatomy for you. All right. So they introduced it through the skin into the heart. Oh, wait, this wouldn't be through the femoral artery, because if it was percutaneous directly into the heart, through the skin directly into the heart, then they didn't come from down there. They came from up here. Okay, but they still had to use a catheter. Now, and that's a good point for you to remember, is when the most common place we hear about catheterization is, of course, through the urethra into the urinary bladder. Okay, but then of course there's cardiac catheterization, which does go through the femoral artery, and that's used often for stents and to look at any stenosis of the heart or any blockage. Okay, but in this case, that's not what they're doing. And this also underscores the necessity for you to read the entire documentation, short or long, so you understand exactly what's going on, because you weren't there. Okay. So they're going to take sampling and pressure measurements documented bilaterally. So in this case, not right and left of the patient, but bilaterally of the heart. You'll notice percutaneously into the heart. They went directly into the heart, sampled and did pressure measurements using that catheter. Now, in this case, the suture is teeny tiny. So they did a simple repair. Zip, 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 zip. Okay, couple of stitches. Patient tolerated the procedure well and was transferred to the recovery room. Okay, so this is why you must keep your medical terminology, your medical dictionary handy all the time. And don't let your anatomy book go too far, because it really can help you when you can visualize using the illustrations and the anatomical sites, because this is very complicated until you're working for a cardiologist. And if this cardiologist does this procedure often, at some point you'll already know. And for those of you who might be a little more, I guess we could call this courageous, you might go ahead and ask the physician if you can observe some of these procedures. Okay? Not everybody can do it. Not everybody wants to do it. Looking at an illustration in an anatomy book is much, much different than actually seeing an actual human being. Okay? But some of you may have that interest and that ability to look at the blood and the cutting into human flesh and be interested in the mechanics, if you will. And this will all make you a better coder, because the better you can understand a procedure, the better you can interpret it. Okay? All right, this only has one code. So close your eyes and you can open your eyes again. Okay, let's do another case study. This is a CT scan. This is going to come out of imaging in the ICD-10 PCS code book. I think you're not there yet in your reading, but we'll give you a little heads up, okay? Because I want you to think about whichever code set, whether it's ICD-10 PCS, which you're learning now, or ICD-10 CM, diagnosis coding, or even CPT, once you understand how to use your coding manuals and do a proper manner of interpreting the documentation into codes, this other language, I liken it to learning how to play the piano. Once you know where to put your fingers and what all the notes are and how to interpret what is in the sheet music to where your fingers are and which keys, then each song may be a different experience. But once you already know how to play the piano, you can appreciate it, each experience for its own. Okay, it's the same exact thing with coding. You are interpreting the sheet music into a key on a piano. You are interpreting the documentation into a code from a particular code set. Okay? All right, let's take a look at this real quick. The patient is a 57-year-old white male with a long-standing history of hypertension, coronary artery disease, and chronic obstructive pulmonary disease, who was admitted for chest pain. Okay. Ooh, I bet he has chest pain, also known as angina. Okay. The patient has recurrent pain episodes and is followed by South City Cardiology. That's where we got to send a copy of the test results and the report. Okay, the patient has had a stress test prior to admission, which did not reveal any ischemia. So that's good. This also confirms that this is an inpatient an inpatient procedure. So that tells you right there, this CT scan is happening in the hospital to an inpatient. It's not outpatient. Okay. And that's particularly important with reports like this because CT scans are done for inpatient. They can also be done as an outpatient. Okay. All right. So the patient is ruled out for myocardial infarction and was stable over 2 nights in the hospital. He also had a CT scan of his heart bilaterally, was negative for dissection, meaning there's no tears or rips, which is good. You don't really want that in your heart. Okay. The patient was discharged to home in good condition without any further pain. So he was here. He's been here for 2 nights. What are we coding? We are coding the CT scan of his heart bilaterally because that's what was done while he was in the hospital, and that's what you're doing. Okay. He is to follow up with his primary care physician, Dr. Lorenz, in 1 to 2 weeks after discharge, and with Dr. McAvoy, his cardiologist. 2 weeks after discharge, he is to resume his home medications. Okay. Now you will see notes like this. Now, of course, in the EHR, in the patient records, but at this point, by the time you get the case, you will have the confirmation that the CT scan was done, and you will have the report from the radiologist. Okay. But I wanted to give you the short bits because sometimes you only get short bits. Okay. All right. So you are reporting a CT scan of the heart bilaterally. All right. 1 code. Close your eyes. Woo. Now open your eyes. All right. 1 more, and then I'll let you go. All right. This is a venous Doppler, also from the imaging section. You may remember a Doppler is a form of sonogram. Okay. All right. The patient is a 59-year-old male patient presenting to the ED, emergency department, with a 4-day history of right leg discomfort and swelling. Patient is also complaining of hematuria and smelly urine with no fever or chills or dysuria. Okay, so medical dictionary's out. Hematuria, oh, that's not good. Blood in the urine. All right. Smelly urine, you probably are familiar with that, especially if you just ate asparagus. And no fever, chills, or dysuria, which means an inability to urinate. Okay. So he was admitted for further examination. Admitted, that's your cue. ICD-10 PCS. Okay. Patient was sent to have an urgent venous Doppler as he was found on clinical exam to have varicose veins with right calf tenderness and right leg edema. Now, remember, we as coders are also the backup for the physician and their documentation. Not only do we ensure by proofing, if you will, reviewing their documentation to make sure it has all the components we need for coding accurately. And if you remember, by the way, there's no such thing as an unspecified code in ICD-10 PCS. Okay. So it's very, very important that we check consistency. Okay. So we see here in the second paragraph, yes, right calf tenderness, right leg edema. And in the first paragraph, we have 4-day history of right leg discomfort. So we have agreement now. It's the right side. Okay. The urgent venous Doppler results were called to me, which is positive for acute right leg DVT, deep vein thrombosis. That gives you your diagnosis. That's going to provide the medical necessity for the Doppler. Patient's urinalysis is also positive for blood and urinary tract infection. Oh, he's got a UTI. We hate that. Okay, but in this particular case, because this is ICD-10 PCS class, you are only going to code for the venous Doppler on the right leg. Okay? 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 All right. You know what to do. Practice this. Questions? Who are you going to call? Well, you're not going to call me. You're going to email me, but I'm not a Ghostbuster, so there you have it. But I am a code buster. Okay, so please practice, 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 practice. If I knew how to play the piano, I would put this all to music for you, but I don't. So please make certain that you practice, practice, practice. And you know, there are also case studies in Connect. If you want more, you let me know. Okay. And it's also in your textbook. Okay. Have an absolutely wonderful day. And if I can be of help to you learning, email me. Okay. All right. See ya.